ASH 2015 coverage continues here in Orlando. I'm Thomas Baldrick. Nice to have back with us Dr. Stephen Ansell from the Mayo Clinic in Minnesota. Thank you, sir. How's your conference going?
It's going very well, thank you. Busy conference, lots of exciting details and information, so it's been a good time.
So you had a presentation here. Let's talk about that if we can for a minute. Clinical outcomes from extended follow-up of a phase 1 study looking at Nivolumab in patients with relapsed or refractory classical Hodgkin lymphoma. Let's talk first about what you did with the design of the study, and then we can get into the follow-up.
This was the first study looking at this PD-1 antibody called Nivolumab. PD-1 blocks a little receptor that's on T cells. T cells that express this receptor get exhausted and don't function very well. So blocking that receptor allows for the T cells to become activated. So it hasn't been tested in hematological malignancies, in particular lymphoma, and this is looking at how it works in Hodgkin lymphoma.
What are you presenting in the most recent data?
So this data actually was presented a year ago as the first report, and the results were very exciting. 89% of the patients responded. The key question was, is this going to be durable? And so this is the follow-up presentation that shows that patients have remained on treatment now for up to 2 years, and that the response rates remain high, and that patients actually tolerate the treatment well.
What do you attribute that to?
Well, I think there's a few things. One is that the treatment activates T cells that are already seeing the tumor. And so when they become activated, they're pretty T cell or tumor specific and focused. And so their effects on other cells actually has been less. So compared to other immune activating therapies, the side effects actually have been less.
Did you learn anything else or prove anything else in the follow-up?
I think the other thing that we found that was interesting, a question was, if you were on treatment and stopped and your disease came back, could you potentially retreat and still get benefit? The numbers are very small, but the people that have been retreated after benefiting before benefit again. So this really appears to be a therapy that one can give for a long time and can retreat as needed.
What do you do next to keep the positive momentum going?
So actually there are two main thrusts of further evaluation. The first is to go ahead and test it in a larger cohort. This was a small study of only 23 patients. So there's a large study now that actually has accrued really fast and is actually completed. The data will probably read out within the next year that will see whether this is really as exciting as we hope it is. And the second strategy is to say, can we now combine it with other new therapies? And so there are combination studies that are in development right now.
And that would be with what else?
So the studies are looking at, can you combine it with other checkpoints? So there are actually completed studies already with Nivolumab and Ipilimumab that target CTLA-4. And there are now studies combining it with antibody drug conjugates like brentuximab vedotin. And there are other studies combining it with more typical chemotherapy.
Very good. Congratulations, sir, on your efforts. Thanks for joining us again.
Thank you very much.